Hello there, hi, Assalamualaikum. This is Nurul here from Center of Medical Imaging Studies, Faculty of Health Sciences, UiTM Puncak Alam. Today, I'm going to talk about radiographic image evaluation of ribs in oblique position. If you find this video beneficial, then you may share this video as a learning material for evaluation of oblique rib radiograph. So yeah, let's get started. I gladly made this video for knowledge sharing, and these are the things I'm going to talk about. I will start with radiographic anatomy of oblique ribs, followed by how to identify the projection. Then, I will go deeper into the criteria of correct positioning as well as the criteria for adequate exposure factor. And lastly, we will discuss on evaluation of oblique rib image by using PACEMAN method. First and foremost, let's start with the radiographic anatomy. One of the basic needs to be a good radiographer is to have a solid knowledge on the radiographic anatomy. This label image shows among the structures that can be identified on oblique projection of the rib. We should be able to identify the right clavicle, corresponding level of the posterior ribs, the right scapula, the right hemidiaphragm, 12 right floating ribs, air-filled trachea, sternal end of the left clavicle, the manubrium, and the corresponding left axillary ribs. It is very important for a radiographer to identify the structures precisely. Next, let's continue with the identification of projection. This is the initial stage of image evaluation. Identification of projection is important because the following criteria of image evaluation, such as positioning and collimation, will be depending on the said projection. This is a radiographic image of ribs in oblique projection. This is ribs because the entire thoracic cage showing the first to the 12 floating ribs, the axillary ribs, as well as the anterior and posterior ribs is included in the radiograph. This is oblique projection because we can see the axillary ribs under investigation are layered out at the lateral edges of the radiograph without superimposition with the anterior ribs. As a radiographer, one should be able to differentiate between the PA and oblique projection of the thoracic cage. As you can see, oblique projection focus more on the depiction of the anterior and axillary rib contour instead of the lung and heart. The delineation of the rib contour helps the radiologist to identify any presence of fracture that will lead to lung or heart injury. In addition, oblique projection of the ribs can be performed in either anterior or posterior oblique position. If you are confused by which way the AP or PA oblique the patient was positioned, remember that the spinous process will always pointed towards the unaffected side. For example, in the left oblique ribs, the spinous processes is pointed to the right. The anterior oblique will project sharper cortical outline of the sternum and is preferred for delineating the contour of anterior rib. In contrast, posterior oblique will give better delineation of axillary rib. So, as a radiographer, you should evaluate the final image to ensure that the radiograph able to address the correct part of the ribs under investigation. Next, let's move to the criteria of correct positioning. The first criteria to justify correct positioning is to evaluate the adequacy of 45-degree obliquity. This can be assessed by evaluating the position of the sternum. Correct 45-degree obliquity is justified by the inferior sternum positioned halfway between the vertebral column and the anterior ribs. The second criteria indicating correct positioning is the distance between the lateral margin of the rib to the spine of the site of interest. It should be approximately twice as great as that of the unaffected site. Furthermore, the axillary rib should be layered out and free of superimposition. Here I provide example of radiographic images to address issue on rotation, as both under-rotated and over-rotated oblique position hardly achieve distance between the lateral rib margin to the vertebral column of approximately twice of the distance between the affected versus non-affected side. It is worth to focus more on the location of the sternal body. Under-rotated oblique position is indicated by the sternal body situated next to the vertebral column, whereas the over-rotated oblique position will project the sternum laterally. So we can state our judgment based on the location of the sternum. The second criteria to justify correct positioning is to evaluate the element of tiltation. This can be assessed by evaluating the presentation of the vertebral column. Correct positioning with no tiltation is justified by the presentation of the vertebral column aligned with the long axis of image receptor or collimation border. Look carefully on these two images. In this image, we can clearly see that the patient was tilted anteriorly, where the long axis of vertebral column is not aligned with the long axis of image receptor. Next, let's look into the effect of lung aeration on the radiograph. As the lung aeration may contribute to provide additional contrast to enhance visualization of the rib contour, taking exposure with proper breathing technique is significant. In recumbent position, normally 9 to 10 axillary rib will be demonstrated above the diaphragm in fully inspiration. On the other hand, in upright position, fully inhalation will demonstrate up to 11 axillary ribs above diaphragm. This will significantly contribute to proper depiction of the rib contour. However, if the patient does not fully inhale, the inferior ribs are positioned below the diaphragm and are not well visualized. And to compensate demonstration of the inferior ribs, the 4 to 6 lower rib will be demonstrated below the diaphragm when the projection is taken in fully expiration with adequate exposure. Next, Let's discuss the criteria to indicate adequate exposure factor. In determining the optimal exposure factor to be given to the patient, radiographer should take into consideration which part of the ribs is of interest. When the upper axillary ribs are of interest, a lower KVP in which high contrast technique is the best choice. It would best define upper axillary ribs without overpenetrating the air-filled lung. This technique provides image with high radiographic contrast. On the other hand, when the lower axillary ribs are of interest, a slightly higher KVP technique is needed to penetrate the denser abdominal structure and visualize the axillary ribs while still maintaining relatively high radiographic contrast. As general rule for each radiographic images, beam penetration, contrast and density should be optimal to demonstrate the structure of interest. For oblique projection of the rib, correct KVP and beam penetration is indicated by optimal radiographic contrast. This can be assessed by seeking the evidence of visualization of the bony cortical outline of the thin structure, which is the anterior rib, as well as of the thick structure, which is the axillary and posterior ribs behind the heart. Apart from that, correct MAS, which contribute to optimal radiographic density and details, can be assessed by looking at the evidence of visualization of bony trabeculae. Optimal visualization of bony trabecular pattern of thin structure, which is the anterior rib, and the thick structure, which is the axillary and posterior ribs behind the heart, is the evidence of correct exposure. Nowadays, with the utilization of digital imaging, issue of overpenetration or overexposed images are seldom. However, issues on underpenetrate or underexposed images are still apparent. Therefore, it is important to critically evaluate the visualization of bony cortical outline and trabeculae of the thin and thick structure as I mentioned before to justify correct exposure factor. Next, we have reached to the last component of the learning outline. Let's discuss on image evaluation of oblique ribs projection using PACEMAN method. Now let's continue our journey to evaluate a radiographic image using PACEMAN. For your information, PACEMAN method is constructed to facilitate systemic approach of radiographic image evaluation and determining diagnostic acceptability of a radiograph. The first component in this method is P, projection and positioning. This is a radiographic image of the rib in oblique projection. This is ribs because the entire thoracic cage, the axillary ribs, as well as the anterior and posterior ribs are included in the radiograph. This is oblique projection because we can see the axillary ribs under investigation are layered out at the lateral edges of the radiograph without superimposition with the anterior ribs. Moving on to the positioning, this image shows incorrect positioning. This is because the patient was positioned with inadequate 45-degree obliquity. This is evident by the inferior sternum located close to the vertebral column. Besides, the distance between the left lateral rib margin to the vertebral column is not equal to twice of right lateral rib margin to the vertebral column. Apart from that, the patient also was tilted anteriorly. This is evident by the vertebral column is not aligned with the long axis of the image receptor. To improve the positioning and considering that the area of interest is at the left axillary rib, the patient needs to be rotated with the left posterior side in contact with the image receptor until the mid-coronal plane form 45 degree to image receptor plane. This will bring the inferior sternum halfway between the vertebral column and left anterior rib. This will also ensure that the distance between the left lateral rib margin to the vertebral column twice as of the right lateral. Besides, ensure that the patient stands straight against the erect bucky with weight equally distributed on both feet and aligned with the long axis of image receptor. This will bring the vertebral column aligned with the long axis of image receptor or the collimation border. Now let's talk about the alignment. There are three components to be discussed under the term of alignment. First is the alignment between the X-ray beam versus image receptor. Second is the alignment between the X-ray beam versus patient. Third is the alignment between image receptor versus patient. In this image, the alignment between the X-ray beam and image receptor, as well as the alignment between the X-ray beam and the patient, cannot be determined because there is no presence of four borders of collimation. Apart from that, the alignment between the image receptor and patient was incorrect because the distance between the edge of image receptor to the central structure is not equal superior-inferiorly and laterally. The centering point for this radiograph cannot be determined since no collimation border can be seen. The standard centering point for bilateral oblique ribs projection is at the mid-sagittal plane at the level of 8 cm inferior to jugular notch, corresponding to level of T7. Let's move to the next element of PACEMAN, which is C for collimation. Collimation should be done to all four borders of the image receptor and should include the first rib at the superior border, axillary rib cage at both lateral border, and, if possible, include the 12 floating ribs at the inferior border. There is no evidence of radiation protection apparatus seen on the radiograph. Next, let's talk about the E element, exposure factor. The KVP used for this radiograph is adequate for penetration and radiographic contrast. This is because the bony cortical outline of the thin structure, which is the anterior rib, as well as the bony cortical outline of the thick structure, which is the posterior ribs behind the heart, can be seen. However, the MAS used for this image is inadequate for radiographic density and details. This is because the bony trabecular pattern of the thin structure, which is the anterior rib, can be seen, but the bony trabecular pattern of the thick structure, which is the posterior ribs behind the heart, cannot be seen clearly. Because there is no clear depiction of the bony trabeculae of posterior ribs behind the heart, this image is therefore classified as underexposed. To improve this, the initial KVP should be maintained, and doubling the initial MAS should be able to improve radiographic density. Now let's move to the M element, which is marker. In this image, there is no evidence of anatomical marker, but digital post-processing marker had shown in the image, correctly placed on the left side of the patient's body and placed appropriately without superimposing any region of interest. The A element of PACEMAN Define about the aesthetic value of the image. The image receptor size used is 35 cm x 43 cm positioned in portrait orientation, which is sufficient to demonstrate all structures of interest. There is no evidence of artifacts seen on this radiograph. We are reaching the last element of PACEMAN, which is name. This image shows no patient's name and identification, date of examination, and place of examination. Those information should be clearly visualized on the image at the appropriate area without superimposing any structures of interest. After evaluation from P to N, now it's time to decide on the diagnostic acceptability of the image. Based on previously said evaluation, the image should be rejected due to absence of patient's name and information, insufficient exposure factor, and incorrect positioning. Repeat examination should be considered with corrective measures taken into consideration to ensure acceptability of the image. Yay, great! Now we have successfully evaluated the image using PACEMAN method. I hope that this video is of beneficial to help you in evaluating radiographic image of oblique ribs. So that's all for me for today. I hope to see you in the next video inshallah. And Assalamualaikum warahmatullahi wabarakatuh. Bye.